Wellbutrin. Um, it's controversial because it's more of a stimulant. It's dopamine agonist, and so it wakes you up. It is not a common reaction, but if you have anxiety with panic disorders, it can make anxiety much, much worse. And so some people do it, and some people, there's some research that says it's only if you see panic disorders, but generally, most psychiatrists say don't use bupropion for anxiety, use it for depression. Um, the comparison is stimulants, Adderall, Ritalin, and the lower end would be coffee. So if you have folks who can't tolerate coffee, a good screening question is how do you do with coffee? And if like I can't do it, my hand starts to shake. If I take more than half a decaf, I can't sleep, then do not prescribe Wellbutrin. This will not go well. So that's a good tip for you guys. Buspirone is very good for the outpatient setting. It's probably the most well-tolerated psychotropic in our toolkit. It's so well tolerated that sometimes you question, does it work? Does it not work? But there is a population for it. And so some people really benefit from it. It's not sedating. It doesn't have sexual side effects. It doesn't have minimal weight gain. A bit of a complicated dosing, but you can do BID or TID. I don't understand the TID one. I always do BID unless someone is looking for PRNs and it's kind of a psychological benefit that you're taking one more pill or one more time. But generally for simplicity and decreasing polypharmacy and pill burden, I always try to do BID dosages. And that's buspirone. Actually, why am I not going through the slides? And then there's gabapentin and pregabalin. And we should avoid hydroxyzine and benzos because of the anticholinergic burden and because of so many side effects. So this slide is about benzos. You are going to have a problem with your patients with benzos. They will want benzos. It will be hard to get them off of it. It will be very rewarding when you do. They are notoriously difficult to withdraw from, and so people are dependent on them. This is associated with worsening cognition, decreased reaction time, increased risk of falls. So really, a lot of potential hazards from using benzos in the geriatric population. There's an unspoken side effect, which is paradoxical reactions and agitation. That happens in all ages, much more likely to happen in the geriatric. So you're trying to help someone who's agitated and anxious by giving him benzos, and then they're suddenly completely disinhibited. And that's probably from the benzos. Long-term use, more than 3 months, can increase the risk of dementia. I don't know if I agree with that, but it does worsen cognition. It can cause delirium, and there's a very big association with bad outcomes.
So I'm just curious, why do you not agree with that?
Because causation is very hard to prove. And there's a very big association, but to say that it causes dementia is hard for me to prove. I don't know how you would prove that in any. And so I haven't seen, and we've seen a lot of folks on long-term use that don't have dementia. So the caveat of all of that is that there are people who are so sick that you end up doing it, and so we try to give you all the red flags and all the things to be careful and to avoid doing, but there are situations where it's impossible, and you want to control the disease, and that's the only thing available for us. So once you do the risk-benefit conversation, you end up doing it. And another set of patients is folks who are in their mid-80s, you just inherit. They come in, they're highly successful, they're highly accomplished, they're married, they have children, and they are on 0.25 milligram of alprazolam for 55 years. And you go and you do this whole spiel that you should stop it. And they're like, please, doc, that's the only thing. I don't want to get worse. And I've been on the same 0.25 for 55 years. Can you please just continue it? And this is where the discussion is, he doesn't have dementia. It's been more than 3 months. And he knows the risks, and the benefit is very clear. where do we stop? If he's really limiting himself to that low dose, is that okay? Is that not okay? Depends on your risk tolerance, and if you document properly. I have a few patients who I stopped trying after the few times where we did and it didn't work, or we tried other medications, it didn't work, and then we went back to it.
I have one other question about the paradoxical reactions. Do you
Sure.
ever like see that develop? Someone's been on it for a long time, but then as they've gotten older, maybe their body's metabolizing it different, that then they might develop a paradoxical reaction later, or it's more like with first time use.
I haven't seen it develop. I think it's possible, but I haven't seen it develop.
More like if they're tolerating it, then
More if that they don't tolerate it.
yeah. Okay.
Gabapentin, the drug that works for everything and nothing. But no, I really like gabapentin, jokes aside. Gabapentin does not increase GABA. It decreases glutamate. It is a GABAergic. Um, it is excreted by the kidneys, so it may need those adjustments with CKD. So you want to pay attention to that. It is not nephrotoxic. It does not make the kidneys worse. It just accumulates more, and hence you might be prescribing more than you should if you're not looking at the kidneys. It does have a large therapeutic index. You can start with as low as 100 milligram, which for most people is nothing, and as high as 3,000 milligrams. So this is why we like it, because you can start really, really low, and so you avoid causing problems with people who can't tolerate it. And if they end up being people who tolerate higher doses and need much more, you slowly build your way up. Uh, it's not unusual in psychiatry to see 300, 300, 600. In pain clinic, it's not unusual to see 900 TID. And so the high doses exist, but also in a very frail 90-year-old dementia patient who's having sundowning anxiety, 100 milligram at 3 p.m. could just do the trick. And so you can use the whole spectrum. It does have multiple indications: seizures, nerve pain, anxiety, mild agitation, insomnia, restless leg, alcohol, withdrawal, and craving. A classic patient is someone with nerve pain and anxiety, or nerve pain and anxiety and insomnia, or if you're trying to decrease alcohol use and you're targeting alcohol. I would caution that, though, that sometimes if people are not ready, don't just throw it in the mix, because people end up drinking and taking the gabapentin, and that just potentiates the situation and leads to worse outcomes. It does lead to less sedation, less tolerance, and less dependence than benzos, so it is a much safer alternative. It is less likely to be deliriogenic, although it does happen. So just pay attention to that. So it's, if you're considering a benzo, consider gabapentin first, and you
I have
can
a
use it.
question
Yes.
about that. So I knew you were saying that like some people it's very like just dependent on what works for them. Because I had one who had like she would do like 100 milligrams PRN and that wasn't enough. Have you seen at like a certain dose like it usually works? Or it just depends on the person of like
You
slowly
really want
titrating up the PRN?
what you want to do is you want to examine the patient, see if first their size, because I think
Mhm.
some of that is depending on their size and their frailty. If they're a healthy, large 6 foot guy, it's different than if it's a frail 4 foot person.
Mhm.
Um, and then another issue is what their life history is, if they're psychotropically naive or not.
Mhm.
If it's someone who's been on benzos their whole life, gabapentin 100 will never be, will be not successful. If you have someone on benzos, you're trying to switch them away from it, I would usually do 300, 400, or 600.
As your
So
starting
if
dose.
they're alcohol users, there's cross tolerance, and so they become tolerant. So you don't want to try 100 milligrams. I only keep the 100 milligrams to folks who are naive, who've never been prescribed any PRN. And so I would start there and go up. If it's someone who's always had tons of PRNs and is a psych patient or is a chronic alcohol user, then you want to start with 300.
Mhm. Good to know. Thank you.
Um, along with gabapentin, I think there should have been a slide here. There's pregabalin, Lyrica, very similar drug, much more potent. Does the same action on glutamate, is also gabapentinoid, is more potent. If you're unsure of if they can tolerate drugs, go gabapentin. If you're thinking that I don't want to burden myself with very high medications, it's a much lower range with pregabalin. It's easier to dose. You can go up to 200 milligrams or 300. It's simpler and it's more potent. It's also a good medication to keep in mind in the same realm. So this is gabapentin. This is anxiety. Just as a caveat, late life anxiety is a very hard entity to address and treat. And we've had a few anxiety resistant to treatment patients, and it's even harder than depression. It's very, very hard. So this is why I caution you guys, and at some point you see people ending up on high doses of benzodiazepines, and sometimes that doesn't even work, and it's related to all the psychosocial situations going on, and it's just very, very hard to treat. I think we're going a bit. Let's talk about psychotic disorders. Late onset psychosis is unusual, and you want to look at delirium if that's happening. If it's the first time you see someone hallucinating and it's acute and it's fluctuating and it has visual hallucinations, you want to look at delirium. You want to look at medication side effects, at medical conditions, substance use, dementia, obviously, and delusional disorders. Late onset schizophrenia usually is in the 45. Very late onset is an entity in the 65s, but it's not very common. Features more common in elderly is more in females, more likely to see visual hallucinations, tactile, olfactory, which are uncommon in the regular population. It is less common to have affective flattening and negative symptoms, which is a good thing because these are the negative prognostic factors in schizophrenia. So generally, psychosis in the elderly is more treatable and a little bit better manageable than young folks. You use antipsychotics for aggressive behavior, agitation, delusions, hallucinations. There is the FDA black box warning against it in dementia, unless you have evidence of psychosis. The black box warning is still there, but you still want to treat the psychosis because if you don't, the morbidity is much higher. This data shows you that the increased mortality is by a couple of %, and it's not that high if you're managing it properly and keeping an eye on the QTC. Even the FDA-approved dementia treatment, which is brexpiprazole, Rexulti, that is an antipsychotic that also has the same black box warning. So to keep in mind that you can't get out of the risk, but you need to focus on the benefits, which is if someone is aggressive, he's going to be at much higher risk of getting into accidents, fights, or hurting himself. The classic limitation for antipsychotics is anticholinergics. Centrally is poor attention, impaired memory, behavioral problem, confusion. Peripherally, it's retention, constipation, very common. This is a classic prescribing cascade. Is you see a side effect, you don't see a side effect from antipsychotics, and you start adding side effects, adding other medications to manage it. It's very high risk of extrapyramidal syndrome, a very high risk of Parkinsonism. That's why we use Seroquel if you have Parkinson's for psychosis, and pimavanserin as first line. EPS occurs as high as 80% in the elderly. Akathisia is very under-recognized in the primary care setting, even in psychiatry. Akathisia is restlessness and an urge to just cannot sit still, move around. And you have someone who's anxious and restless and psychotic, you prescribe a medication like risperidone or Abilify, which are notorious to have akathisia. They become more restless, and you don't pay attention. You increase the medicine even more and more, and now they're so restless, you don't realize it's from the medicine. You add to it a benzo or another sedating drug, and that leads to a fall. And then so it's good to keep, when you're prescribing psychotropics, to be systematic and look at the dosing and what happened and how it increased or decreased, and be mindful of the risks. This is the best way to use those medications because they're not benign. and you could be causing some side effects inadvertently. Mitigating EPS. Benztropine is common in the adult, not in the geriatrics because of the anticholinergic effects. Propranolol is commonly used for akathisia, amantadine for Parkinsonism and rigidity. TD is protracted tardive dyskinesia from the antipsychotics. You can use VMAT inhibitors. Tetrabenazine is the older one, which can be drugged, the dose TID, initially for Huntington's. Better drug is deutetrabenazine, which can be dosed BID, and more recently valbenazine, which is only a once-a-day dosing, but very expensive and very hard to get approved. So these are the options for TD. They do work well, but interestingly enough, we start them, we send folks to memory disorders. Sometimes they tell us to try decreasing the dose and see if that, so it can sometimes be confusing because they can also have some movement side effects. Okay, another limiting side effect is cardiovascular, orthostasis, hip fractures, arrhythmias, things to be mindful of and monitor. Atypicals are better tolerated, and they are recommended over first generation antipsychotics. Most commonly is Seroquel, clozapine, risperidone, olanzapine, and Abilify. Seroquel to be considered, I would say, only when you have Parkinsonism. Risperidone as a first line if you don't have Parkinsonism. That's the opposite of the spectrum. Olanzapine would be more sedating, a bit closer to the quetiapine, and Abilify would be more activating. It's the only one that's agonist-antagonist. So at the lower dose could be stimulating. It's good to use as an augmenting treatment for depression too. There are newer antipsychotics. I think they're listed at the end. Bipolar, very briefly, in the elderly is 25%, 60% females. Across that. Mania, you would treat it most commonly with lithium and valproate, very efficacious. Unfortunately, a lot of side effects as we grow older. Lithium is classically leads to a lot of CKD, but also very prone to toxicity if folks get dehydrated and have an AKI. So it becomes harder to manage, and we try to get people off of them, but sometimes it's necessary. Carbamazepine is effective, but has a lot of drug-drug interactions. And for bipolar depression, there's tons of newer antipsychotics to be considered, just for you guys to know. Lurazidone is a good medication. It's activating. It's good for bipolar depression. It's notoriously difficult to treat entity. Cariprazine is also a newer one. It's called Vraylar. It's partial agonist. And Caplyta is a newer one too that focuses more on HT2A antagonism than on D2 blockade, so less likely to cause EPS. All of those are newer medicines that are good for antipsychosis as options, but also more importantly as mood stabilizers and in bipolar depression. We talked about lithium, VPA. VPA is also very good drug, but if it has a side effect, it's very hard to tolerate. Can lead to a lot of sedation, especially if combined with an antipsychotic. Rarely causes encephalopathy on a check ammonia, and you want to keep an eye on blood dyscrasias, on platelet levels, and on the liver functions. Whew, we made it. This is the end. I think there's a few slides on things you want to ask other than just diagnosing the entity, is keeping an eye on substance use. A lot of folks drink and underreport, and most recently use a lot of cannabis for various reasons, for appetite, for sleep, for pain, for fun. It's very variable potencies, and THC is much, much more potent than it used to be. And so a lot more side effects, a lot of more psychosis and anxiety from cannabis. And loneliness, just ask who's with you. Who did you see anyone during the week? So keep an eye on loneliness and keep an eye on grief. These are very, very big confounding factors that make all the situations worse. These are my words of wisdom. We made it. Thank you for bearing with me. I have some time for questions if you have questions.
Hey Omar, it's James.
Hi. Are you
Hey,
next?
what'd you say?
Are you next?
No, no, I was just listening to your. I'm so glad it's getting recorded. So,
Nice.
one thing I wanted to tell the fellows is, thank God this is recorded because you'll want to, listen to this again probably before boards, and Omar's one of the smartest guys I know. So, if you're getting to work with him, ask any psych questions. Just a wealth of information. Especially like I think you didn't you said it really quickly because it was towards the end, but I think it's interesting you mentioned about the differences between the antipsychotics, the second generation, and preferentially using risperidone as opposed to Seroquel, which a lot of times we know in the hospital setting, that's the go-to one for, oh, this dementia patient has agitation or there's a delirious patient, either Haldol or Seroquel, and most of them feel more comfortable with Seroquel. I didn't know if you wanted to, if you said something about kind of the anticholinergic effects of like a delirious patient on Seroquel and commenting about maybe that might not be the best one for multiple reasons, but one of them is you're kind of worsening the anticholinergic burden with them. Is
Yeah,
that
no,
is
I
that
think
true? My understanding?
yes, it is absolutely true. I kind of brushed towards the end because I felt rushed.
Yeah, no worries. I feel like we should
But
give you 2 hours.
but there are some the anticholinergic effects of antipsychotics is under-recognized. And so especially I think Seroquel and Zyprexa are very commonly used in the hospital setup and don't realize that if you have a delirious patient, it's hard for you to really differentiate which one is causing what. But a lot of the time it makes things worse and you don't really
Yeah,
realize. And on the when we were on the inpatient, a lot of the times we were victim of giving more and more and not realizing that the patients were agitated and more confused, but they're so confused that it's hard to gauge. And then we made the decision to stop the olanzapine and or the quetiapine, and things got much better. So I prefer risperidone, to be honest, unless I see serious EPS, especially at the lower doses. It is if you're serious about treating paranoia or psychosis, you can start with 0.25. This will make sure most people tolerate this dose, and then work your way up towards a more effective dose as they tolerate it. And that is much less likely, has basically no anticholinergic or less likely to cause confusion and worsen the picture.
right. I have another question, but I'll let the fellows ask if they have any questions.
And I just also want to look at the time. I see that
Oh,
Dr.
shoot.
Burnett
Yeah, yeah,
has
you're right.
joined.
You're right.
So we might have to, luckily the fellows all get to work with Dr. Goosen,
I know. It's
coming
wonderful.
starting
Yeah.
next week with Emily. So
I'm
um
listening in too. It's pretty intriguing though. So
okay, good. Well, if there's a last question, otherwise I think we would go ahead and we'll turn it over to Dr. Burnett. Does anybody have anything burning for Omar? Otherwise, thank you so much
Thanks,
for
guys.
joining. We'd
Yeah,
love to
thank
spend
you.
more time with you. Yeah.
My big pleasure. We'll see you
Thanks,
soon.
Omar.
Okay.
Bye.
Um, well, welcome. Is it okay with everyone if we just go ahead and go right into our next lecture or a session and then we'll take the break afterwards? Okay, perfect.
either way, or if you guys want like a 5 minute break, like I totally understand that sometimes didactics is a lot to take in. So
I'm just going to grab some hot water, but it'll take me less than a minute.
okay, and then I've given this lecture before, so I'm not sure how many people have heard it or not heard it before.
None of them have
None
heard
of them have heard
it.
it. Okay,
Yes,
and
we're a 1 year.
I also wanted to bring up there are more things besides urinary incontinence that we take care of, like in older women. So if you'd like, I don't know if you have lectures on prolapse and that kind of stuff already, or because I have two slide decks up just in case, depending upon what things you're most interested in hearing about, whether it's like pelvic floor disorders in general, including urinary incontinence, or whether you want to just stick straight to only urinary incontinence and dive in it way too deep.
What do you guys think?
I would love to hear a little bit about prolapse because I feel like it's very common and
And sometimes I get referrals for prolapse because like providers are concerned because they see things, or patients go to the ER or they send providers pictures, and so and they kind of are related to one another, right? There's some things that kind of relate to one another sometimes. So Anyway, I have a slide deck of Taking Back the Floor where we can talk about all pelvic floor disorders, or
It
we
sounds
can stick to only UI.
like a combo may be perfect. Is that
Yeah,
like, yeah.
or another option is if you're willing to come back, we could probably fit another
Sure.
session in or something to do that. But I don't know, whatever. I'll defer to course Rupali. But
Either, yeah, it's your
A
how.
big chunk of it is urinary incontinence, but I also see a lot of patients with recurrent UTI too. So I have a couple slides
yeah,
on that
that's
that might be
wonderful.
really
Oh, great.
helpful. I was just
Yeah.
kind of
That
in
would be really
preparation for
good.
this, thinking about like what would I want to know if I took care of an exclusively like older population.
That's
So okay.
actually awesome. All of that sounds
Okay, because
perfect.
I'm
So maybe
also
we'll
our like
push.
just retooled our UTI guidelines for our clinic
Yeah.
Oh
and
wow.
really can give you hopefully some insight because we're also retooling referrals and things for recurrent UTIs. So, okay, so we'll just
Fantastic.
take back the
Okay.
floor and do that because it'll be a little bit different and a little fun. Um,
Wonderful. Thank you so
Let
much.
me just go because I was debating. I'm like, do I use the same old slides that I've been using forever, or do I do something like a little bit different? And I figured maybe it was time to mix it up a little bit 3 years into this. Okay, so we'll just kind of start by talking about pelvic floor disorders in general, of which urinary incontinence is one of them. And I would love participation and for you guys to blurt out questions and ask me about things as we go because I'm really passionate about talking about this sort of stuff and would love to get like feedback as to what is most helpful for you guys in your practice and what things you want to know more about. And so just to start off on like what pelvic floor disorders are, we kind of think of these as falling into, a couple of major categories. So pelvic organ prolapse, which is when organs that are usually on the inside start coming out through the vagina. So think of this as a hernia, but through the vaginal orifice rather than a hernia through the abdominal wall. Urinary incontinence, of which there are two major types, things like stress incontinence, which is leaking with coughing, laughing, sneezing movement. We'll get into that in a little bit more detail in a minute. But also urge related, where people feel like they can't make it to the bladder in time. Mixed when they have a little bit of column A and a little bit of column B, which is a vast majority of our patients with urinary incontinence. And then in more rare circumstances, things like overflow incontinence, but I'll talk about that a little bit more, especially in the setting of prolapse, since sometimes it can kink the urethra and prevent the bladder from emptying completely. And then we also, as pelvic floor urogynecologists, treat things like fecal incontinence, although GI also contributes. Sometimes, too, there are anatomic reasons for fecal incontinence, things like posterior pockets and prolapse that can contribute. So we see these patients often in combination with GI and colorectal surgery. And then the other thing that we treat a lot of, it isn't like exclusively a urology thing at all, is recurrent urinary tract infection. And so our clinic has a lot of newer tests for some of this stuff. And I have maybe hopefully some answers for some things that might be kind of annoying in the recurrent UTI space too. And so, just as a reminder, these conditions currently affect over 40% of women, and this is predominantly like older women, as the one of the most common reasons to develop or most strongly associated clinical risk factors is aging. So this is all the people that you're going to see that are living longer and are having weird things happen down there. And although these conditions aren't life-threatening, they severely impact the quality of life for people in general. And there was a study in JAMA in like 2016 where they had people rank conditions in terms of quality of life or which things they'd want to have happen to them and which things they thought were worse than death. And so bowel and bladder incontinence is actually ranked as worse than death by more people than things like relying on a feeding tube to live or being confused all the time. So, although these conditions don't kill people, I really, really do recommend like screening and asking because sometimes patients won't volunteer this information, and you can change lives in a very, very meaningful way with sometimes very simple interventions or very simple referrals to come see people like me. So pelvic organ prolapse. So this is like a little picture of kind of what this stuff can look like sometimes so that you don't get too scared if you see it in real life. Occurs when the pelvic floor muscles and the connective tissue weaken or tear. And this can cause pelvic organs to fall downward into the vagina, similar to a hernia. And women may feel or see tissue coming out of the opening of their vagina as this progresses. And from a urogyne standpoint, we think of this like anatomically for the different compartments that can be involved. So Things that are in the anterior compartment, like shown here as a cystocele, like our anterior prolapse. So this is when people are saying like my bladder's falling out. It's not like obviously the bladder itself, but the vaginal wall that is shared with the bladder, so the vesicovaginal interface, and so the bladder can sink down lower in the pelvis. Rectocele is like loss of posterior compartment support. So that's when the rectum is deflected like more anteriorly and bulges through the vagina. This can happen with lots of straining and constipation. So sometimes this can be more acquired, whereas cystoceles and apical support usually is a result of vaginal childbirth. Loss of apical support. So the apex is like the top part of the vagina, right? And so that's when that's lower compared to other parts. And this doesn't matter so much for you guys, but it matters kind of for us as to what we're doing or thinking about for treatment. But overall, the treatments are very, very similar, regardless of the type of prolapse. And so, again, very, very common. Many women have prolapse and experience no symptoms. So, about 83% of women that have had a vaginal delivery have some degree of prolapse. But I tell my patients it's kind of like saying, of the people that are older and have had babies, are your boobs in exactly the same position as they were when you were 21 and before you had babies, right? So it's not really like it's necessarily dangerous. It's just that sometimes as that tissue gets lower and lower and lower, it can become bothersome. And so things in terms of bothersome symptoms is usually the most like the striking feature will be bulging from the vagina. So people complaining about bulging from the vagina, not being able to wear a tampon, obviously not for a geriatric population, vaginal dryness or irritation because the tissue can rub on clothing, trouble urinating or having bowel movements until the prolapse is pushed upward manually. So sometimes you'll see people for overflow incontinence, and it's because the bladder is not completely emptying. And so one thing that can be done is manually reducing the prolapse, and then this straightens out the path between the bladder and the urethra to facilitate urination. And then urinary incontinence or accidental loss of urine is a common complaint, but it's not necessarily caused by prolapse. These are sort of, things that kind of go together. We already talked briefly that pregnancy and childbirth are major risk factors for this. So 1 in 3 women who give birth have prolapse, like symptomatic prolapse. And being pregnant and having vaginal deliveries can damage the pelvic floor muscles that support all these tissues to maintain their position in the pelvis. Especially true of women that have had severe lacerations in their past, big babies, bad tears, that kind of thing. Aging and menopause, so loss of estrogen with menopause, along with other changes with aging, can weaken the pelvic floor. Part of this is muscular atrophy that happens obviously globally throughout the body. But also it's thought that like cumulative muscle loss in conjunction with prior injury can really worsen these conditions in older populations. Certain health problems, so these are usually health problems with greater degree of intra-abdominal pressure, like straining, obesity, chronic cough, constipation, can really injure the pelvic floor over time. Weight loss is actually a really, really, really successful intervention for stress urinary incontinence, and we'll talk about that a little bit more later. Heavy lifting and things like that, sometimes people are more symptomatic because things are pressing out of the pelvis. And then there are people that have genetic predispositions, things like Ehlers-Danlos and stuff like that, where there's collagen tissue defects where they just don't have the structural support that they might have had otherwise. And so our treatments for pelvic organ prolapse, there's a couple of things. You can wait and do nothing. So if it doesn't bother someone, or it's like, it's very mild and it's not interfering with urination, you don't need to do anything. Pelvic floor muscle exercises on your own. So teaching people how to do Kegels during like a pelvic exam, or sending them to things like pelvic floor physical therapy are great ways to start for women with symptomatic prolapse, and even in pelvic floor physical therapy, also for urinary incontinence and other pelvic floor disorders. And then we also use these things called pessaries, which I'm sure you guys do maybe some of, I don't know, maybe. Volunteer, whether you've ever fit a pessary or seen one?
Not really enough. And like, I actually know nothing about the management of them. Somebody asked me
Oh,
recently, like, does the patient do it? Do they have to like have it exchanged monthly? Like, I actually had no idea. So I would love to hear about that.
so pessaries, they come in a variety of like shapes and sizes that you see over there. There's the ring and the Gellhorn, so the one on the upper right and the one on the bottom left in that picture are probably like the most common ones. The ring pessaries, usually people, as long as they have good manual dexterity, can get them in and out on their own because they're not so, the other one's kind of like more of a suction cup and push all the way up there and it's harder to get in and out. But the rings, usually people can get in and out on their own. For women that can remove and replace them by themselves, usually we say take it out like once a week, clean it, put it back in, just soap and water is fine. There's actually excellent data showing safety of using pessaries up to 6 months at a time without removing them. So we generally book people that can't remove and replace their own pessaries every 3 months in our clinic, and then that way, if they miss a visit, we get them within that 6 month time frame. The things that can happen with pessaries that can cause problems if they're left in, particularly for long periods of time, is they can erode the surrounding tissue. So imagine, I mean, I tell people this is like a sports bra for your vagina, right? It holds up the tissue, but it can rub in weird places. And in general, if you leave it on for long, long periods of time, you might have weird discharge or things might smell a little funky. And so it's nice to take it out and clean it and put it back in. And so in severe cases where people forget about pessaries for long periods of time, so patients with cognitive function issues that don't get follow-up, I've seen them erode into neighboring structures. So into the bladder, into the rectum. And so when that happens, it's a really big deal. So pessary care is important, but isn't really something that has to be that frequent. So the biggest thing is make sure someone knows that patients have to come in. So the times that I've seen really bad complications is when caretakers are not aware the pessary is in there, right? Nobody knew. And then all of a sudden they're leaking a lot. They come into clinic and we discover a pessary that's eroded into the bladder. So that being said, I've had patients that have come in that have been like, I don't know how long it's been up there. It's been at least 5 or 6 years that have been completely fine. So the thing that you can do to for pessary users to help them not have erosions is vaginal estrogen therapy. So always, always, always think about vaginal estrogen therapy in people with pessaries, even if their urogyne has forgotten, or even if they're not really, or they're doing their own maintenance, but now maybe they've gone from being premenopausal to postmenopausal, because it can help a lot with preventing pessary complications. Julia, any more questions about pessaries or things I can answer?
Is this like something that has to be specially fit to each woman, or is it something that like you could just prescribe a one size fits all?
Usually we fit these. For the urinary incontinence ones, I'll show you there's like some over-the-counter options. But for prolapse, you really need one that is matched to the size of the vaginal opening, like the genital hiatus, and is going to work for that particular patient. Some of the challenges in pessary fitting, and I'm going to back up, 92% of women can be fitted successfully with pessary. So people with prolapse that are symptomatic, that are scared of surgery, you can assure them right off the bat that there's a really good chance that they will find a pessary that works for them. It just might take a little trial and error. Risk factors for not being able to be fit with a pessary are having a history of a hysterectomy, mostly because the anatomy of the vagina at the top is a little bit different. So it's not quite as wide. It's more like an upside down ice cream cone. And so it's harder for things to kind of stay up and in place. And another risk factor that kind of goes along with that is like a large vaginal opening. So if the genital hiatus is really large, so if you have someone bear down and you see their prolapse come out and you also realize that like the vaginal opening is like 7 or 8 centimeters wide, it's much more likely that the pessary is going to come out. So, but send them over and we will try to fit them with whatever pessaries we have. But for continence pessaries, there's over-the-counter options.
Cool. Thank you so much.
I had a quick question.
Oh yeah.
Sorry. So for the vaginal estrogen, you're saying kind of can you use it like prophylactically for people to prevent any issues from the pessary? Do you use that in like I know you probably don't use it in everybody.
Everyone.
Are there certain like
Yes.
or do you?
Everyone, basically.
Everyone.
Yeah. So it's the best thing we have at preventing recurrent urinary tract infections. It reduces urinary tract infections by over 60% in some studies, and as high as 75% in others. So it's really effective at that. Really good at maintaining vulvovaginal health and preventing like BV in people in general, but especially in pessary users where the risk is a little bit higher. So there are very few contraindications to vaginal estrogen use. Basically, the only one is active breast cancer treatment. So vaginal estrogen is safe in women with a personal history of breast cancer as long as they're out of their active treatment window. And overall, vaginal estrogen use doesn't raise systemic hormone levels at all. And they just removed all the black box warnings on all the hormone products. But we were lobbying really hard to remove them on vaginal estrogen because it scares people so much. For people that are scared of the applicators, because the applicators a lot, especially for like older populations, they're like, how far do I have to get this in there? I usually just say put a blueberry sized amount on your fingertip, get it anywhere in the vulvovaginal area, because a lot of times their symptoms are much more lower urinary tract and urgency related. And so having it near the urethral meatus actually works really well. And don't worry, throw the applicator in the trash. Like you don't need it. For women that struggle with being compliant with it, because they're forgetting and other things, the E-string is a great option, or for women with limited hand mobility. So older ladies that just like can't get things in and out of their vagina in any sort of meaningful way, the E-string is a great option. It's every 3 months. And so usually it's also awesome with pessaries because they'll come in for their pessary change, they'll bring in their next E-string, we'll trade everything out and they'll be ready to go. So there's excellent data showing compliance is better with E-string, but that's just because you don't really have to think about it as much as you do with the vaginal estrogen cream.
Cool.
Other questions on that? I'm very passionate about vaginal estrogen in case you can't tell.
I would love to hear all of your stuff. So
Using on vaginal estrogens, yeah. So anyway, if people need a pessary, we're happy to fit them. It is kind of a needs to be fit kind of thing compared to the continence pessaries if it's for prolapse. And then there's surgery options for prolapse too. So for people that are like, no, that pessary thing sounds horrible, rest assured that there are plenty of surgical options, and this is just a few of them that are listed here to help meet needs in terms of prolapse management. So on the left, there's some that are geared at restoring apical support, so bringing the top of the vagina back where it's supposed to be. In general, I mean, I hate to make it sound so simplified, but all of these surgeries are sewing the top of the vagina to strong ligaments in the pelvis, okay? Plus or minus some mesh and some other things, okay? Like that's the big picture, what's going on with these surgeries, because we haven't really solved the underlying cause or been able to reverse or prevent it in a meaningful way. So we have these lovely delayed compensatory methods of treating this condition. So for a sacrocolpopexy, it's basically mesh on both sides of the vagina and then sewn to the anterior longitudinal ligament in the pelvis. A uterosacral or sacrospinous ligament suspension is exactly what it sounds like, which is sewing the top of the vagina or the cervix to the uterosacral, like foreshortening the uterosacral ligaments, or sewing the top of the vagina to the sacrospinous ligament. There are basically overall some native tissue repairs, like things with your own tissue versus things with mesh. Things with your own tissue are actually pretty effective. So for 85% of women, this will be all they need for the rest of their life surgically. So it's kind of a one and done thing. These are same-day discharge surgeries. This is not like a big deal, even if you're a geriatric person with a little bit of medical problems. Sacrocolpopexy is a little bit bigger because it's a laparoscopic surgery, but with the mesh, the durability is a little higher, things on the order of 95%. Compartmental support, so fixing like the front or the back wall, those are all done native tissue. There is no advantage to using graft augmentation. There's been numerous studies on that. And these are about, I don't know, depending upon the size of the repair, 30 to 40 minutes in the OR, same-day discharge surgeries. And then even for women with really, really severe prolapse and lots of medical conditions, there's an obliterative procedure called a colpoclesis, where we basically skin the front and the back wall of the vagina and then sew the vagina walls together to obliterate the prolapse. And it has over a 99% success rate. And there's no entrance into the peritoneal cavity at all. Almost zero risk of bleeding because it's just skin there and is incredibly safe even for very sick patients. So even though these, the word surgery has like certain annotations and connotations, these are very, for the most part, very low risk surgeries. A lot of times people have questions about hysterectomies in older populations. Sometimes they're more concerned about whether or not they've had postmenopausal bleeding or history of abnormal pap smears. And so you don't have to have a hysterectomy as part of a prolapse procedure. I get more questions about this from like my younger patients. I direct the pelvic health after birth program at UCSD, where I see a lot of women with prolapse that want future childbearing. And for those women, we don't do hysterectomies, but we can still offer surgical repair. So no hysterectomy is required to treat prolapse. Basically, the surgical outcomes for these procedures are identical. And so there's lots of options, regardless of whether or not you have a uterus and regardless of whether or not you want to keep your uterus. What about mesh? And so I'll just take a quick talking point because a lot of people have a lot of fears about urogynecologic surgery because of some mesh stuff that went on about, gosh, like 10 or 15 years ago now. And this was so at the time that the mesh controversy was going on, there was an ongoing pelvic floor disorders network trial, which UCSD is one of 7 sites for the pelvic floor disorders network. And we were recruiting patients to a couple of different arms. One was a sacrospinous hysteropexy with a graft, so a procedure with a mesh augmentation versus one without a mesh augmentation. And basically, what we found when we looked at the data, even though the study was stopped in the middle because the FDA pulled the mesh from the market, the outcomes are actually better in the group with the graft than they are in the group without the graft. And the complication rates are basically the same. And so this is kind of flies in the face of like pulling this stuff from the market, right? Because you're like, if it's so good, why did it get pulled from the market? And part of that was because, so like, wait, isn't mesh bad, right? Because FDA pulled it from the market. There's all these things about like, were you injured by vaginal mesh? Like, are horrible things going to happen to you? And so the big problem was that outcomes are great when, get this, people that are trained in urogynecology are placing the mesh. So initially, when these mesh kits came out, you didn't have to be urogynecology fellowship trained. You could go to a weekend course in Vegas, get a kickback from a company, and place permanent mesh implants in women in spaces that you had never operated in. And so this was initially introduced in the late 90s. And then ultimately, like the training fellowship that I've completed, that wasn't even a board certified fellowship until 2013. So a lot of the data that came out with pain and erosion of mesh, mostly those procedures were done by people that had no formal training in how to do these surgeries. And so I just bring it up because a lot of people have questions or are scared to come see urogynecologists because they think we're going to implant them with horrible mesh. And I think the point to be made is, you know, you're only as good as the person that's using those tools, right? So for instance, if you give my 8-year-old and a Michelin star chef the same ingredients, you get a very, very different meal and has nothing to do with the tomato. So just a little reassurance that mesh in and of itself is not a bad thing. People not knowing how to use it and placing it is a bad thing. So when placed by trained urogynecologists, even transvaginal mesh, like the one that's been removed, is safe and effective. And so the thing that really impacts like what outcomes happen for surgery is surgeon experience. Like who does your surgery is just as important as what surgery you're having done. And so we still use mesh for procedures transabdominally. They have better success rates than native tissue repairs. And so we still do that, even though it sounds like something scary. And what's best for patients depends on a lot of things, what their symptoms are, what their medical history is, what their surgical history is, if they're sexually active, because that obliterative procedure, you can't have penetrative intercourse anymore, but sometimes when you're in your 90s, you don't really care. And then other coexisting conditions like things like urinary incontinence. And so we talked a little bit about this before, but I'll kind of highlight it here, is urinary incontinence can be influenced by prolapse. So you can see in the picture on the right that the prolapsed bladder, see how the urethra is kind of starting to kink. And you can imagine if it were out even further that it might limit the ability to empty the bladder. But then when you anatomically correct this and the bladder's in the correct position, now it's very easy for urine to come out. So sometimes women have urinary incontinence after prolapse surgery because the bladder is now in the correct anatomic position. And like I mentioned before, there's two major types of urinary incontinence. We think of urge urinary incontinence as like rushing to make it to the bathroom in time and not being able to make it, and overactivity of the detrusor muscle of the bladder. So this is that overactive bladder, or the technical term now has been reassigned to like urgency associated incontinence. And then stress incontinence is thought to be a problem with the support structures for the urethra, so that the urethra moves a little bit and leaks urine with things that are the things that involve increased intra-abdominal pressure, right? So like coughing, laughing, sneezing movement. So even for women that you see in the clinic, asking like little questions about, well, when does it leak, can give you a little information about what to do, right? Because someone with urgency incontinence, you might want to start them on a medication, because like feel free to do all that stuff. We love it when you guys try things out first, and then we kind of pick up the pieces later if it doesn't work. And for stress incontinence, you might want to tell them to get like an over-the-counter device for urinary incontinence called a Poise Impressa, and I'll show you some pictures of that kind of stuff too. And then always feel free to just refer. We're happy to take care of people too. I just want you guys to feel empowered to do things as well, right? Like, because that way we overlap with one another and can help each other out. Both types of incontinence are improved by pelvic floor physical therapy, so never, ever, ever hesitate to send people to pelvic floor physical therapy. And both types of incontinence are improved by vaginal estrogen, not systemic estrogen, but vaginal estrogen. So stress incontinence, we talked about how it can be worse after a prolapse repair because of how the bladder is sitting relative to the urethra. There's just something to keep in mind. And for us, we diagnose it by doing what's called a cough stress test, which sounds more sophisticated than it is. We actually just visualize the urethra, have them put one foot up on a stool so we can see a little better, and then have them cough really hard and see if urine comes out of their urethra. It's not, yeah. And there was actually a large PFDN trial to see if we needed to do more sophisticated testing, because everybody was previously doing a test called urodynamics, which is the thing shown here on the right, where you put catheters in the bladder and a catheter in the rectum, and you fill their bladder and you ask them about things. And it turns out that if you have uncomplicated stress incontinence, you don't need to do all that and subject patients to all that. You can do the standard cough stress test, which is like a full bladder, and have them cough and see if they leak. And then you can check a post-void residual and make sure that they're emptying okay. Do you guys have the ability to check post-void residuals in your clinics?
We do.
Oh, perfect. So if you have people leaking and you're worried about stuff, you can always check bladder emptying, either using a bladder scanner if you have one available, or a catheter if you need to, and then just don't tell them you have a bladder scanner available. Tell them you're going to take a really clean specimen for UTI testing, and also check emptying at the same time. And for people with surgical histories or other complications, or you're really not sure, send them to us and we'll probably be equally confused and send them for urodynamics. And urodynamics is meant to be a more objective measure of what's going on in terms of stress versus urge incontinence. So treatment of stress incontinence, pelvic floor exercises and pelvic floor physical therapy. So if people can do a Kegel with you on exam in the clinic, they can do and try those things at home without going to physical therapy. Some even older women are surprisingly good at this, and they just need to kind of engage those muscles at the right time and practice doing that. Poise Impressa is a little device that it's almost like a tampon that goes inside the vagina and then deploys to kind of put pressure on the urethra to help with continence. There's also one called Revive that's a reusable bladder support version, so versus like a disposable one. And then there are continence pessaries. So these are the kind of one size fits most-ish, depending upon vagina size, but there's a knob to put pressure on the urethra and keep the urethra closed, okay, for stress incontinence. And then surgical options for this are basically twofold. One procedure is called urethral bulking, which is this procedure shown here. And I tell people this is a filler injection for your urethra, right? So imagine Kim Kardashian's lips, but your urethra, and we're just going to go and we're going to inject this. It's 95% water, 5% polyacrylamide gel. So exactly what you probably like ran gels on if you took like lab classes back in college and stuff. They made it into a slurry and charged $1 bazillion for it. I should have been so smart as to think about this. But basically, it's a gel slurry injection in the urethra to make the urethra more closed. So this is the little device that we use over on the left. It's like a little cystoscope with a needle so that you can target your injections. The picture kind of in the middle-ish is showing before and after bulking, showing where the bulking agent goes to kind of close the urethra. And then the pictures on the bottom right are showing what the urethra looks like, more wide open versus more closed. And this is not bad for efficacy. So it has overall about a 65% dry rate or cure rate, but about half of women need 2 injections to reach this efficacy. The upside is this is something we do in the clinic. Like we can do it in the clinic. You can be dry that day. There is no downtime. There is no recovery. So it's really good to be able to offer things that, you can tell them, look, hey, there's minor procedures that you can do in the office to help fix this, and it really is pretty effective. And we have 7-year outcome data on Bulkamid, and I think they're working on publishing their like 15-year data, but I haven't seen the newest paper yet. The other thing that we do is something called a mid-urethral sling. This can be made out of mesh or your own tissue, which, your own tissue sounds appealing until I explain to people that I have to go take it from somewhere else. So it's like, it's not cadaveric tissue, really, it's your own tissue from usually the fascia, the abdominal wall fascia. And so we don't routinely do this. I probably do it like twice a year for people that are really, really terrified of mesh. But there's a higher risk of hernias and other things and pain, and it's a much longer surgery. Whereas using synthetic polypropylene mesh, we have data from the 90s showing safety and efficacy of these procedures. So really, it's kind of the gold standard to use mesh. These are basically an 85 to 95% dry rates. These are like usually completely curative for people. There are a couple different flavors and variants that I won't bore you about because you probably don't have to think about this too much, but there are ones that go behind the pubic bone, ones that go out to the side, shorter variants where we've tried to maximize safety and efficacy. And so sometimes we'll tailor and use specific slings for specific patient populations, but overall they do the same thing, which is provide a support for the suburethral tissue to keep it from moving to prevent leakage with coughing, laughing, and sneezing. And they work really well. And one thing that's kind of weird about the mid-urethral sling is it seems to both help stress incontinence and urge incontinence. So about 2/3 of women that have like a mixed picture actually have their urgency completely go away with this too. If I had to make a guess, I think it's because sometimes the suburethral support is so weak that there's just a little urine that gets into the urethra and gives that urgency feeling, but we don't really know exactly why this is. There is a risk of difficulty voiding. I tell people that basically anything that makes it harder to leak also will make it a little harder to pee. And so sometimes you just can't sit down and pee instantaneously. You have to be a little bit more thoughtful about it. Short-term voiding dysfunction after surgery is really common. About 30% of women will go home with a catheter on the day of their procedure. Long-term risk of voiding dysfunction is really rare. So 1 to 2 days later, 98% of women pee without a problem. There is the risk of mesh exposure. Again, very, very low, like less than 3%. Usually it's not patients that are bothered, it's sexually active partners. So, because mesh inside the vagina is really horrible for partners, and most female people don't notice at all. And then there are options without mesh with your own tissue, like we kind of touched on briefly. And then switching gears to any questions about stress incontinence?
I just have a question. When you're looking to provide women with like a beginner script of pelvic floor exercises, what do you generally tell them?
I usually do it with them. Do you guys routinely do gynecologic exams as part of your practice or not usually?
Not usually, but I'm more like if you're telling that like let's say that we did, ensure that okay, they know how to do it properly. How many like sets and reps are you recommending they do in a day?
Oh, I say everybody's really different with what they're able to do. Like imagine you're asking them to go do a bicep curl and you're trying to describe like how many sets and how much weight, right?
Okay.
So if I'm trying to cue them verbally, like the verbal cue that works the best for me, and I just confirm because I'm doing an exam at the same time, but you don't have to, is think about picking up a marble with your rectum. I know it sounds very weird, but people are not used to thinking about like rectum being involved, whereas these pelvic floor muscles span, right, all the way from the pubic symphysis to the coccyx. So it's that entire pelvic diaphragm that's being lifted up. In terms of sets and reps, I usually say hold it for up to 10 seconds. Most people can't do quite that long for holding, right? So you might start them at like, you can say start at like 3 or 5 and do maybe 5 of them at a time and then do 3 sets of 5.
Okay.
The pelvic floor physical therapy, this is really depressing. Long term doesn't make a huge difference, okay? And it's not as depressing as you might think, though, because it's like saying if you go to a personal trainer for like 5 or 6 sessions, does that make you exercise for the rest of your life? And so the most important thing is actually compliance with any of this.
Sure.
So I tell them the most important thing is not necessarily exactly how many sets and reps you're doing on a given day. It's figuring out a time and place in your life to do these things. And I usually give the example of, for me, it's in traffic because I'm already like, anyway, it's like, can feel my pelvic floor engage. And I'm like, oh, this is my cue that I should be doing some Kegels right now. So just like other forms of exercise, they have to like find a time and a place to do this kind of stuff and do it in a more meaningful way to maintain musculoskeletal mass. And I tell them the upside of this compared to other exercise is you don't sweat. Nobody has to know you're doing it. You can do it during a Zoom meeting, right? You don't need special equipment. You don't have to be in a specific place, right? And you don't have to wear specific clothing. So this should be the lowest lift of all exercises out there, right? Even though some people still, so it's like cueing in of when I should be doing it in my daily life is probably the most important thing. And then you can always, if you're worried about them coordinating, like having coordination, or if you do an exam and you tell them to do a Kegel and they like wiggle their butt cheeks at you, you could always send them to pelvic floor physical therapy to learn how to do it, right? Like learn how to do the bicep curl, but then ultimately the heavy lift is doing it doing it for the rest of your life. So, but you guys know that because you guys probably counsel on all the lifestyle stuff all the time anyway. But this is no different than other musculoskeletal health.
It's the hardest thing.
It's the hardest thing. People hate hearing it, right? They want like a magic fix, or I'm going to go to this PT for like two sessions and it's going to be done. So anyway, urgency incontinence. The definition for urgency, or the diagnosis of urgency incontinence, is they have urgency and then they like have to rush to the bathroom. It can be quote unquote wet or dry, like where you're having urgency and you don't leak, or it can be urgent and you leak on your way there. Now, the problem with this is that really doesn't encompass like the etiology of any of this stuff, right? So you can have urgent urinary urgency because you drink 10 lattes a day, or you can have urinary urgency because you have diabetes and a neurogenic bladder. So the problem is like we don't treat those any differently. Even though there can be a huge difference. So probing a little bit about what they're drinking and like that kind of stuff can be really useful. And sometimes like bladder diary, like having them write down what they're drinking and when they leak can be diagnostic and therapeutic. And it's always helpful for us if they come with a little bladder diary, because I can be like, oh, I see you're drinking 10 lattes and that every time you have a latte, you have leakage, or, you'd be floored at what people do. So I usually say average, like fluid intake for a day for a normal weight person with normal levels of activity is somewhere between 60 and 70 ounces. And I've seen people drink over 200 ounces in a day, and you're going to pee more frequently if that happens. So always feel empowered to have people keep a little diary about how and when their symptoms are bothering them or what's going on, because you'd be pretty surprised at what happens. A side note, because I don't have any sides on this, nocturia, also something to think about. Usually fluid intake before bed, and then pedal edema and sleep apnea are the three big drivers for nocturia, at least in my experience. I don't know if you guys have a separate lecture on all of this stuff or not, but people are floored sometimes by the sleep apnea relationship. But basically, there's hormonal cues to get rid of more liquid, and then you make more urine overnight. So the other thing that kind of comes along sometimes with voiding diaries is looking if you give them a hat and they write down how much they're peeing. Like if they have normal voids, right? If they have 300 or 400 milliliters out every time they pee, their bladder's telling them the right thing, right? It's different than someone who's peeing like 50 milliliters at a time, whose bladder's telling them the wrong thing, right? Because they're not full at that point in time. You'd also be floored at the number of behavioral triggers that are out in the world. I know the ones for me. It's when I tell my kids that we're about to go somewhere and I tell them, okay, time to go potty. Even if I emptied my bladder 2 seconds before, it's like I have an overwhelming urge to urinate. It's kind of like a Pavlov dog thing that we do to ourselves. The other one for me is like waking up in the middle of the night. So it's like, doesn't matter if I went to bed 10 minutes earlier, if I get woken up, I'll feel like I need to use the restroom. So encourage people to be thoughtful about what's going on. And sometimes they'll figure out their own like things or triggers because behavioral interventions is a good first line, first line thing for this condition. So we talked about lifestyle and behavioral modifications, and then we'll also talk a little, always refer, there's no harm in pelvic exercises in PT. And then we'll talk a little bit about medications, because I imagine you guys probably prescribe medications for urinary incontinence too. There's basically two major classes of medications: anticholinergics that block cholinergic receptors in the bladder and stop detrusor contraction, and beta-3 agonists, which is the other way. So they're stimulating adrenergic receptors in the bladder to, again, stop contraction. I'm sure you guys probably know already that there's a huge relationship between anticholinergic drug use and dementia later in life. So I almost never prescribe anticholinergics. I usually fight with the insurance pre-authorization and write something aggressive in the chart, like patients over 65 and not eligible for anticholinergic medication. Or I'll write something and be like, hey, I think you tried this before, right? And so maybe they failed this medication, they should move on to a beta-3 agonist. So there's almost no circumstances in which I write for anticholinergics unless it's really episodic symptoms. Mirabegron comes in 2 doses, 25 and 50. Usually I tell people to start with 25, try it for a week or two, and then if it's not enough, increase to 50. The things to think about with mirabegron is there is some data that it worsens blood pressure. If you look at the study really carefully, the systolic blood pressure increase was 5 millimeters of mercury on average. So it's not like scary blood pressure increases at all. So I'm not saying like never prescribe it in people with hypertension. What I do is I have patients that are taking it that have hypertension, take their blood pressure and see what it's like after a week or two. And I've had exactly 2 patients in the past maybe 7 years that have for some reason had like crazy high blood pressures after taking mirabegron. Vibegron is in the same class. There's only one dosing once a day, which is 75 milligrams. And that one's not thought to be associated with blood pressure problems at all. And neither of these medications has been associated with dementia. Questions about any of that, since this is probably the most likely thing that you guys would prescribe? No?
Just a quick logistical question. Yeah. So it's been easier for us to get the mirabegron first as opposed to that different now, or still the case?
It should be. Try it. I mean, it's been easier for us lately too. But I think it like took all these papers coming out for it to not be such a fight anymore. But I do still like document, like I'm like, this patient's over 65 and not a candidate, you know?
Right. And then between the two, the mirabegron and the vibegron, is there one that you're finding easier to get?
No,
or
it's honestly, some insurances seem to cover one over the other. So I usually write for mirabegron first just because it has 2 doses. So it gives people a little leeway of having like a lower dose and then adjusting up. Okay. And then if it shoots back as like, oh, insurance doesn't cover this, but they'll cover vibegron, then I give vibegron. For people that are super paranoid about hypertension or they've had lots of trouble and they're terrified of starting anything that might mess with their blood pressure, sometimes I'll write vibegron first just for peace of mind, even though I think the data on mirabegron influencing hypertension, like it really doesn't, if you look at it in total, it doesn't really change blood pressures that much.
And anecdotally, I haven't found it to really make that big of a difference.
Again, 2 people in a very long period of time. But for those that I just have them take their blood pressure and just see what it is. If it skyrockets, we just switch. And then, so anticholinergic drugs linked to higher dementia risk, unintended side effects, all this stuff. So things to be aware of, which I'm sure you guys know more about now, but was a mystery for a while or was like a controversy for a period of time. And then on our side, so if medications and behavioral interventions and PT is not enough, or they're like tired of that and they want something different, there are lots of other things that we can do too. So Botox injections in the bladder is straight up like Botox in the face. It's just paralyzing the muscle. So there's nothing special or fancy about it. It is exactly what it sounds like. So we do a cystoscopic injection of Botox into the bladder to relax the bladder wall. Usually people come in about once a year, once every 9 to 12 months for Botox injections. So it lasts a long time. They don't have to remember to take a medication. It can increase risk of retention a little bit in the immediate period, but that often wears off and is pretty rare. And there's a little bit of a higher risk of UTI with this procedure. As you can imagine, like jamming something into the wall of the bladder might seed the bladder with like microbes that are present in there. We give antibiotics around the time of the procedure, but just something to keep in mind because this wouldn't be like a recurrent UTI thing. Percutaneous tibial nerve stimulation. So this is stimulating the tibial nerve, and then it comes back up and shoots up into the bladder and can help with bladder regulation. For people that have a hard time coming into clinic, because the regimen that's been studied the most is coming into clinic once a week for 12 weeks and then monthly maintenance therapy after that. There's a couple of things that are evolving. So now we just all got trained on Altavia, which is like a little implant that goes in the ankle to help with this, so that you have continuous stimulation. And then I've also sometimes just talked to people about TENS units and TENS unit stimulation for at-home stimulation. So for patients that can't come into the clinic all the time or want to try something at home and they're waiting for an appointment with us, like you can always try we have a handout even, I'm happy to send you guys, for TENS unit at home tibial nerve stimulation. Again, unlikely to hurt anybody, and if it works, it's magical.
So I had a patient in one of my like a sleep clinic that had one of those implantable
Yeah.
tibial nerve. And she was coming from the Bay Area, I think like Palo Alto. She'd been
Yep.
treated at Stanford, and she was like, I can't find anybody down here who can use my Altavia or my implantable device. But that was a couple months ago. I don't know if it's changed now
We
or
just did all the like lab stuff for it. Like we did all the cadaver training and we're going through the PVAC process now. Yeah, I forgot how much I hated feet. I'm like, so I was like, oh gosh, I really like cadaver feet is like not my jam. I'm like, I'll do that, but only if you cover up the foot. But yeah, so it's definitely something that's like in emergence right now. There's a couple different variants. One's called Blue Wind, one's called Revi, and then the other one is called Altavia, which is the Medtronic device. The benefit of the Altavia is that it's super fast, like it's not subfascial, so you don't have to go into the fascia of the ankle in an area that I have to say I have not operated or dissected in a very, very long time. And be near the neurovascular bundle in that area. So I'm like, yes, let's do that one. But some of the other devices are a little bit smaller. So there's advantages and disadvantages. And right now, at least at UCSD, we're trying them all on and we're trying to figure out what to do. And we're pushing them all through PVAC so that we can kind of make decisions based on outcomes. But you're right. There's not as much going on in the space right now, but we're in the process. So hopefully something we can offer more. And then sacral neuromodulation has been around for quite a while. It is a nerve stimulation device that instead of being placed in the ankle is placed in the S3 foramina and stimulates the sacral nerve roots. So this is particularly good in patients with fecal incontinence and overactive bladder because it's the best treatment for both of those things. So these nerve stimulation devices are pretty great. They have a much higher efficacy than some of the other treatment modalities, but it's a little bit of a bigger lift because it's a pacemaker for your bladder, basically. So it'll treat urinary retention, overactive bladder, and also fecal incontinence kind of all in one potentially, which is kind of wild. So anyway, there's lots of weird things out there. Questions about any of that? I know I don't have a ton of time. I'll skip over this. It's basically bladder pacemaker. Bowel incontinence, sacral neuromodulation is the gold standard once you've done like once you've done fiber and, Imodium and Miralax and that kind of thing. So I'm sure you guys get plenty of experience with constipation. So, why is the pelvic floor physical therapy effective, right? This is the whole pelvic diaphragm. And this is why that marble with your rectum thing kind of works, is this whole diaphragm of muscles that span from the pubic bone to the coccyx. And then other things to do to prevent pelvic floor disorders, like maintain a healthy weight. You guys know all this, but sometimes it's worth telling people that they also will leak less if they do these things too, right? maintain a healthy weight, control diabetes, stop smoking. Weight is really, really, really a big thing, like bigger than you might envision. So even a 10% loss in weight is over a 70% reduction in stress urinary incontinence. So like if you need to motivate people to lose weight, or if we're just giving everybody GLP-1s now, I'm not really sure. But weight control can really help with these problems. And then switching gears, because I'll spend the last like 5-ish minutes on recurrent urinary tract infections, because I imagine you'll want to know what those are about too, or have to deal with all that stuff. There's a lot of debate in our field about what is a urinary tract infection. So from a diagnosis standpoint from ICS, it's like typically a standard urine culture of greater than 10 to the fifth colonies in monoculture. So there's only one bug there on a voided specimen in a symptomatic patient. So you should not be getting urine cultures on people that are not symptomatic. Sometimes it's very tricky to decide if people are symptomatic, and sometimes symptoms in older people can be really weird, or unexpected. And so this definition doesn't include any insight into the pathophysiology of urinary symptoms or UTI recurrence. So it doesn't really help us with a lot of things that sometimes give us trouble. I'm sure you guys know that UTI is a huge problem. So annual incidence of about 10% in women, huge healthcare costs, lots of people. And about 30 to 50% of women experience recurrence within 12 months. And recurrent UTI is technically defined as 2 or more culture-proven UTIs in 6 months or 3 or more in 1 year. And these have really devastating consequences. So there's a lot of depression, impaired sexual function, loss of being able to do daily activities, and women are disproportionately affected compared to men. And 70 to 80% will have breakthrough infections, even on active antibiotic suppression. So the things that we have out there are not particularly good for it. The tools in our toolbox are few, but not zero. Vaginal estrogen administration is the best tool that we have, and I'll kind of go through these. I think I have like a little bit more details. Vaginal estrogen administrations are best thing. Don't deny people vaginal estrogen. Give it to almost everybody. D-mannose, there's mixed data on D-mannose, and I think that probably stems from how it was administered in some of these clinical trials, and also what kind of bugs it's most effective on. And then antibiotics are, it's a mixed bag, right? Like antibiotics is kind of what we have right now for treatment, even though it's not like my favorite thing in the world. So vaginal estrogen, the thought behind vaginal estrogen administration is that vaginal estrogen increases lactobacillus populations in the urogenital microbiome, and that with more lactobacillus around, you make more lactate, you drop the pH, and you create an environment that's not hospitable for uropathogens like E. coli. So the whole idea is change the pH and get things like under control and have the good bacteria there rather than the bad. D-mannose, it kind of looks like the mannose residues that line the lining of the bladder. So there's sugars that line the lining of the bladder. And the idea is it's kind of like a decoy. So it tricks the E. coli into binding to it instead of binding to the lining of the bladder. So it's probably something that might work better for E. coli-based infections. It's also just completely peed out. It is a not absorbable sugar, so you don't absorb it at all. It doesn't negatively impact glycemic control in diabetic patients. In fact, it looks like there's some data the opposite direction, that it seems to improve things potentially. And there's basically no risk associated with it. So although it's not like consistently found to be effective at all, I'm sometimes not against it either, because for the people that it does help, it's magical, and the risk benefit profile is not bad. Does that make sense? Like, so it's like no risk, and if it helps, great, But it probably needs to be taken twice a day because you just pee it out. And I think some of the studies that were looking at it before, I think the dosing was kind of a little off, and the types of infections you get with recurrent UTIs are not always E. coli. There's a little bit broader and more E. faecalis and other stuff. And then antibiotics, you guys know what antibiotics are all about. And obviously they trash microbiomes in a number of settings and can be a little problematic. Do you always need to treat with antibiotics? Elderly patients, it's a little more tricky, but in younger patients, there's excellent data showing that spontaneous cure of symptoms and bacteriuria can be achieved in about a quarter of patients just by using things like Motrin, Tylenol, and increasing fluid intake. And so we don't always offer antibiotics as part of our pathway. We do offer conservative management of UTI in people that are reasonable candidates for that. And are there alternatives to antibiotic treatments? So a couple of things. There's vaccines that are out there. Euroimmune is available in Mexico, so some people have been doing that, even though there's not like excellent data. There was another one that was targeted for E. coli in general that was recently stopped due to inefficacy. And then we also here at UCSD have a phage therapy trial going on. We're one of the sites for the phase 2, the national lead for that trial. So a phase 2 trial for a phage therapeutic for recurrent UTI. So send me all your recurrent UTI people that that are trial eligible, or please feel free to epic message me if you have someone that you've really had trouble managing or is having trouble getting into Urogyne and think might be a good candidate for that. Yeah, Dr. Aslam and I are leading some of that and phage therapeutics. And so overall, the goals are, we kind of like want to look at mechanistic understanding of disease and improve clinical care. Okay, yeah, and then may your coffee, pelvic floor, intuition, and self-appreciation be strong. So I think I barely made it under the time I tried.
That was fantastic, though. Thank you so much. With like all your little pearls and little communication tips were like just wonderful. Thank you.
It's a hard population to deal with and regulate sometimes. Our biggest thing right now is we used to treat everybody over like a certain age as complicated UTI. Which flies in the face of AUA, IDSA, and other guidelines. So I revamped that, and now we have a lot of like, why am I not getting the same amount of antibiotics that I got before? And I'm like, because here at UCSD, we believe in evidence-based care, and evidence evolves. And we would like to provide you with an evidence-based treatment and not expose you to unnecessary antibiotics because the recurrence rates are exactly the same. So anyway, if you get pushback from people about prolonged antibiotic courses and other stuff, there's a lot of weird stuff in that space, like really weird stuff. Live UTI Free has a website that has like more like evidence-based information for patients. But these patients are very, very challenging because this becomes something that's like both psychological and physical and a very like it is not wiping the wrong way and other things. And I think historically there was a lot of this like, you're unclean or something's weird. And so they're obsessed with wearing certain underwear or wiping certain ways. And I'm like, there's no relationship. Like likely these bacteria got embedded in the wall of your bladder and kind of flare up when you're stressed out and you're not doing something wrong that caused this. It just happens to some people and we're not very good at figuring out why. I think it's probably a host immune sort of thing. That's a whole research topic that could take another hour, but so I won't go into it. But I think there's probably issues with bacterial clearance and regulation of bacterial clearance that we don't quite understand, rather than just necessarily like the presence or absence of uropathogens. Because when we look at urinary microbiome research, there are women that are totally stone cold normal, asymptomatic, that have E. coli in their bladder, like lots of E. coli. So we're just got to be careful with who we treat and what we assume is bad. But if you've tried vaginal estrogen and some D-mannose and then Hiprex is also an option for recurrent UTI, although a little bit of caution with that because it can increase LFTs and other stuff. I had a patient whose LFTs went through the roof right after I prescribed it. I'd never seen it before, but turns out it can. Those are also there's some options out there, but feel free to if vaginal estrogen hasn't helped, send them our way. We're happy to take care of it. And we can do intravesical gentamicin too, so you don't have to have systemic antibiotics. So we have a lot of weird tricks up our sleeves over in the Urogyne division. And we appreciate how challenging these patients can be to care for.
Well, thank you again. That was just
This is
phenomenal. And I guess we can email you if that's okay. If
Yeah,
there's additional questions.
please.
Okay, great.
Email or epic message. Happy to
Great.
answer questions and help out. I love collaborative care and am so grateful to be here and help out and teach.
Fellows, let's all keep Dr. Burnett in our heads. So like we're in clinic and we have a challenging patient, we can be like, oh, let's message her. She said it was okay.
Totally. And then a side note, I highly recommend there's like a Sanford Compassionate Communication fellowship I just finished, but
Yeah.
there's one for fellows that's like leading the way or something that's yeah, because it can be frustrating, right? So anyway, there's resources out there to help you feel empowered to care for difficult patients in a variety of circumstances. So
Well, thanks again. Have a wonderful
awesome.
week.
Thanks, guys.
Thank you.
Thank you.
Thank you.
Okay. Ian, I see that you're signed on. Would it be okay if we took just like a 2 minute, 3 minute break? Just
I'm gonna
because.
be so fast in the bathroom, like so
Unacceptable.
fast.
No breaks ever. This is fellowship.
I've been doing Kegels for the past hour. I need to go.
Have at it. Yes.
So how about 4 o'clock? I'm sorry,
I
3:40.
I
We'll be
was
back up.
planning on making it a briefer session today anyway, so yes, it's completely fine. Enjoy
Okay, we'll
your
be
break.
back in.
Let's
Okay.
meet back here at like 3:45.
Perfect. Thanks.
All right, we could probably just get started. Um, so welcome to another fun-filled dementia discussion hour. You did you have a chance to watch the next two in the webinar? I believe it should have been 3 and 4, the behavioral symptoms and the hospice stuff. Perfect. Well, like we did last time, I think let's go through them, go through the lectures, less as a presentation itself and more a discussion of thoughts and questions you all happen to have. So we can start with one of my favorite sections, the managing non-pharmacologically behavioral and psychologic symptoms of dementia. I'll open it up for just opening thoughts that y'all had on this lecture, or questions, concerns.
I can go first. So
Yeah.
I thought it was interesting. They said like they were comparing one, just like the difficulties of jobs of being like as compared to like an air traffic controller and being a caregiver for someone for like Alzheimer's dementia. And
Mhm.
I think that was like such a good comparison. I think it's like there's so much weight that's put on the caregiver, and a lot of caregivers are like thrust into these situations that they're not prepared for. Or never thought that they would have to be in that situation. So I think it was so interesting. Like a lot of what they were talking about was like the caregiver and like setting expectations. And a lot of that is like maybe caregivers are expecting patients to do things or to be able to do things that they won't ever be capable of. So a lot of that is like there was a lot of emphasis on caregiver education, which I thought was so important.
It's so true. And, that's, I think, the nature of dementia care is, it's if the patient was kind of left to their own devices, they'd be fine. But it's really with the interactions with others that all of these behavioral symptoms start to manifest. It's one of the issues that we see in the hospital, for instance. A common example I often give because I see it all the time is, patients are on donepezil and then they decide that they don't want to eat anymore because their stomach hurts, but maybe they've got a little expressive aphasia and they can't necessarily tell us their stomach hurts. So what do we do in the hospital when that happens? We put them on a one-to-one for feeds to try to get them to eat and encourage them to eat. And here comes the airplane, but I don't want that, so I'm going to swat the spoon away. Now the patient's agitated. Now we're calling security. The patient's escalating because all these scary guys are coming by and they're holding him to the bed, and on come the restraints. And then with the restraints comes the antipsychotics, and it kind of snowballs from there. And so that's why, it's so important to kind of focus on this whole DICE thing of doing this root cause analysis of figuring out exactly what's going on, because we can't necessarily teach and counsel the patient to be like, hey, let's reflect on that where you were just fighting all the security guards and think how we could manage it differently next time. They're not going to remember it. But we can educate the staff. We can educate the caregivers on how to interact. And most behavioral agitation is due to interactions with caregivers. And it's the crappy thing about being a caregiver is you're their family member. You've interacted with them in a certain way for however long you've been together. And now suddenly you're having to change that role and get out of the spouse role and become the treating provider basically for this patient at home. And putting yourself in that new mindset, seeing them and seeing the way that they interact and that they act to you, not as a normal human interaction, but as a thing we have to be analyzing and figuring out how to almost pathologically respond to in such a way to de-escalate situations. It's not something any of us are trained to do. And so, when we are talking about behaviors in clinic, it's a very fine line we have to walk with the caregivers of helping to educate, to explain that they have to change how they interact. We can't change how the patient interacts. And it's impossible to do it in a clinic visit. You start making some headway, but it's one of the reasons why we are so lucky to have resources that we do in San Diego, like Alzheimer's San Diego and Southern Caregiver Resource Center, which can really help with this stuff. The hard part I find there is getting the caregiver to actually go to those places. And you can tell them over and over again how important it is they get there, and they're like, yeah, that was amazing. But actually getting them to get there and pick up the phone and make the call and interact can be difficult. And so it's one of the challenges that we have with doing this type of care. But it's important, because if we can't change those behaviors and the way in which we're interacting, it's just going to escalate, and we're going to need more and more psychotropics and more potential harm associated with it. Other thoughts?
Yeah, so I thought one of the sort of interesting approaches that they discussed was like the idea of using that sort of psychobehavioral approach to like, all right, we know that this patient has dementia. Let's take that out when we're thinking about some of these behaviors and try to like think about them as like, let's just say this is a purely like psychiatric issue, and what are the signs and symptoms, and what do those symptoms align with for the best fit from a psychiatric standpoint? And sort of like when you sort of have that bucket, can I kind of help you like, exclude other sort of biases and things that maybe would prevent you from really like addressing the patient's behavioral concerns and how to best treat them.
Yeah, absolutely. And the psychobehavioral metaphor is helpful for the non-pharmacologic interventions and for the pharmacologic. And I feel like in clinical practice, that's probably the term I wind up using the most in the hospital, and frankly out too, is the psychobehavioral metaphor, and talking about that, because it's easy to manage dementia when you're in the mild stages. It's give donepezil, hope for the best, and see every year to do a MOCA. But once the behavior set in, that's when nobody really knows what to do. And we try to say, hey, there's guidelines to do this, or that, but all of it's just based on what's been studied. And what's been studied hasn't always been the best done. But I saw a patient just today in clinic, actually, who was coming in. They were being followed even by psychiatry at the neurology center, and they had come over to UCSD for a second opinion. Patient with fairly advanced dementia is exit seeking a lot, and keeps like getting anxious because she lives at home with her husband, and most of the time there's a caregiver or her daughter there at the house. But 3 days a week, the daughter has to go to work, and they don't have enough money to pay for the caregiver all the time. And yeah, they're in the guide model, but they only get $2,500 a year total for caregiving. So that's like maybe a day of caregiving. So it's not enough. And so they're like, there are times that we just have to leave her with her husband. And then she freaks out because her husband doesn't do anything with her. And so she's anxious at home and doesn't know what's going on, and doesn't know why they're just sitting around doing nothing. So she gets restless, and she gets up and she tries to leave, but they live right near a freeway. And so we're having to run out and stop mom from running onto the freeway all the time, but we can't place her because we don't have enough funds. And so we went to neurology center, and they said, okay, fine, let's put her on some Rexulti, because that's the evidence-based antipsychotic for treating behavioral agitation. And we did, and she improved, but then she was sleeping all the time, and she stopped walking. And, she used to be able to say yes or no, and now she doesn't talk at all. And so we saw neurology here, And they stopped her Rexulti and they started her on mirtazapine. But now she's getting agitated and restless again, and we're worried that she's going to go run for the freeway. So what do we do? Um, and the answer is psychobehavioral metaphor it. When we're thinking about her behaviors, they're not psychotic. So of course antipsychotics aren't going to be the right choice. She's not paranoid that people are coming to get her, and so she's running for the freeway because she's worried the intruders are going to come in and snatch her from the home. She's just impulsive and restless. And that restlessness, that high energy, I've got to do something, I got to be moving, is more on the hyperactive side, more on the mood disorder side. And so using a mood stabilizer would be more effective for that. And so, was mirtazapine the right choice? No, because she's not depressed. And, I drilled down deep and she had zero depression symptoms, has never had depression her whole life, isn't really anxious either. She's just restless. And so that's why the symptoms were starting to come back, is that they decided to switch her to an antidepressant. Now, of course, it's an antidepressant that also sedates, so it's a little bit better at night because she just sleeps. But it's not really the outcome that we want. And so what's the answer? Get rid of the mirtazapine and try a low dose of some Depakote. Because a mood stabilizer is probably going to be more effective and have lower burden associated with it. You give any of these meds, and eventually you'll get effect, but usually you'll get effect through oversedation. And so that's what was happening with the antipsychotic, is that you give enough antipsychotic, and yes, they will stop doing whatever they're doing, but it's because you've snowed them into oblivion. And so, using that psychobehavioral metaphor, you could then tailor treatment to get a better effect. But of course, she had liver stuff, so we're like, Depakote's probably not going to be the best thing right now. Maybe we need it in the future, but we really should have a psychiatrist guiding this. So it was a referral to psychiatry, and it was a talk to family about, well, let's root cause analysis it and see, is there a way we can adapt? In the meanwhile, while we wait for psychiatry and wait for all these labs to make sure that it's safe to give the Depakote. And that's also where the psychobehavioral metaphor comes in. I then spent time having them just describe exactly what's happening when those behaviors are going on and what's happening when the behaviors aren't there, because it's such a night and day difference of, when the daughter's there, these behaviors don't happen. And so really what happens is that the daughter has gone to Alzheimer's San Diego. She's done a lot of reading. She knows how to behaviorally redirect. She knows how to engage and distract. Husband just doesn't. And so, really the answer there is to start with some non-pharmacologics. And so that's one thing that we spend a lot of time talking about is, probably the best thing for her is if she's restless and wants to move, on the days you're not there, we need to have her in adult daycare. Oh, but she doesn't like going to adult daycare because when she's there, she doesn't know what's going on and doesn't see her family. That's because you're hovering over her too much. And if you just released her and gave it some time, she'd forget and she'd go with the flow. And so it was a lot of time trying to empower them into accessing adult daycare, because that's really what adult day is geared for, is to take patients, identify what issues they're having, and adapt the daycare around them to integrate them and to get them engaged and active. But yeah. Other thoughts?
Okay, so another thing I really loved was some of the common behavioral things we were talking about with dementia. And I really liked, and you kind of touched on this just now with that patient, which was like the wandering part. And it's like, what are those triggers that are causing them to wander? So maybe it's a mood thing where they just feel sort of restless and things like that. But the other sort of triggers, like sort of like boredom, right? Like they don't have somebody to like interact with, lack of physical activity, like they're not walking anymore. Or just sort of that, but even things like dietary factors like sugar and caffeine I thought were interesting. But just like, I think that sort of root cause analysis of like the wandering behavior, because it's so easy to just be like, there's the problem how do we stop that problem with like a downstream therapy or something, as opposed to
Mhm.
like diving more into the upstream causes. So I thought that was it was a good trigger for me to think about those sorts of things.
Yeah, definitely. And when we're thinking about these behavioral problems, it's always the key is we look at if they've arisen, what is it that's changed in a patient's setting that has caused this? Is it that they've had a new medication started? Is it they've had a med stopped? Is it that they've had a new illness? Have they had a new change in family dynamics? Sometimes it's, oh yeah, we just got so tired of watching mom that we've put her with my brother, and my brother doesn't know how to manage dementia, and then they start bad mouthing the brother, and it's like, well, maybe you should teach him before you just dump mom in her lap. Um, but we often can uh, help a significant amount with that kind of root cause analysis. And a lot of these I find too wind up being med related. So one of my big questions whenever I'm seeing new behaviors is always first and foremost, what's changed in your meds? Because oftentimes there is one. Um, I think Will and Julia have both heard this, but there was this whole psychobehavioral metaphor thing applies not just to dementia, but to delirium too. And so this is something that we should be doing when we're seeing patients in the hospital for delirium and trying to figure out how to treat them. The teams are always like, what psychotropic should I give? It's like, no, what should you change in their environment that's going to fix this, and use the psychotropics as a last resort. But like a nice example of a patient that I saw with this recently in the hospital was this surgical service patient that up at La Jolla that the surg-onc team had called saying, hey, we've got this guy and he was admitted to us like 7 days ago for a cancer, and we did all these surgery stuff, and they blather on for like 10 minutes talking about all the cool stuff they did to resect the tumor from his neck. And it's like, whatever. And eventually they're like, well, that happened like 7 days ago, and he was doing fine, but now he's suddenly delirious. And they're like, yeah, last night, it was like 2 in the morning, and he suddenly just like really wanted to get out of bed, and we called security to bedside, and he started punching the security guards, and we had 6 security guards at bedside, and his wife was in the corner crying, and it was just a terrible experience. And finally we just gave him a B-52, and he went to sleep. um it's like, well, that'll do it, I guess. But the first thing that I did as they're talking is I just looked to see the meds, and sure enough, at midnight, a new med popped up on his list, and he had hydroxyzine 25 milligrams Q6 hours PRN insomnia written for him because he was having some trouble sleeping. And so the intern decided to give him a little bit of Vistaril because, hey, that's good and it's not Benadryl, so it's safe, right? We're seeing a lot of hydroxyzine given out in the hospital lately. I'm not sure what it is. It's just in vogue these days, and people think it's safe. But sure enough, he got the hydroxyzine 2 hours later, punching security guards. So went by and talked to them, and sure enough, there was nothing else medically going on that could explain it. And so talked with him about the dangers of hydroxyzine, and we shouldn't use that again. His nurse was in the room at the time, and so she wrote in big letters on the whiteboard on his room, "No hydroxyzine." And that night they stopped that. They're like, "What else should we give instead?" And I'm like, "Nothing." And they wouldn't settle for that, so I said, "Fine, give him like 2 of melatonin or something." It's like it's not going to help anything, but it's not going to hurt anything. And sure enough, next day, no agitation, no punching security guards. By day 2, delirium was resolved. And it wasn't a matter of he needed something different at night. It's that this was something that we did. So we always have to look to see what is it that's changed. And many a time it's the medications. Food refusal as well. Next time you see a patient who's demented and malnourished or refusing food and not eating, check and see if they're on an acetylcholinesterase inhibitor. Most of the time they are, and most of the time we could stop the food refusal just by stopping that medication. Very, very common side effect. But everybody's resistant to stopping it because they're like, oh no, it's helping their dementia, right? Yeah. If you're getting malnourished from donepezil, that's going to kill you quicker than if we just let dementia run its course without it. So oftentimes the risk-benefit trade-off favors stopping that med to improve the food refusal.
Hey, Ian, can I ask you a question?
No.
No, okay. I'll text you afterwards then. No,
Yes, absolutely you can.
you mentioned, educating families, and one of the things I've ran into that is a very big challenge is when you're talking to the family and you're trying to educate them on using a lot of these non-pharmacologic, like figuring out what's going on, like all the things you said, and they're a little more resistant to saying kind of like, well, I know him best, and we know
Mhm.
that this medicine worked, so let's just do this. So I don't know if you have any pearls to kind of help with because I know you've done these conversations a million times. So
Oh yeah, it's hard, and it's just like with the how to manage the behavior itself is that there's no right answer because it's going to be different based on every family member and how they interact, how they think, etc. I find the conversations often work better offline, or when the patient's not there, which is sometimes hard in the room. But if you've got supportive staff to just like sometimes I'll just grab our social worker at memory disorders and be like, hey, can you come sit with my patient for a bit? And then I'm gonna take the family and show them where the bathroom is, and instead walk into the next room and talk to them about what's really going on. Sometimes that de-escalates the barriers because I think part of it is that they want to show off that uh, they're putting their best foot forward and they're doing what they can to help the patients, and they don't want
that's
to
true.
upset them by talking otherwise in front of the patient, and that sometimes helps. Um, the other thing is that I find one thing that sometimes works is using metaphors. A lot of families really take to the you wouldn't interact with a toddler this way
Mhm.
metaphor, because it's, especially having now raised multiple toddlers, I'm realizing there is many a similarity between how we behaviorally redirect dementia and really, really hysterical child who didn't get their 30 minutes of TV and got 25 instead today. Um, and using the toddler metaphor sometimes helps in terms of explaining, we have to think about them and their brains and that they are processing things differently than they used to. And, you're not going to win the argument. And understanding that and adapting to it and telling some white lies here and there may be necessary. When it comes to medications, I find if you explain the medications in the right way, usually you can dispel any resistance, because the families aren't really attached to the medications most of the time. The families are attached to what they think the medications present. So like the acetylcholinesterase inhibitors are a big one. I have lots of attendings telling me like, hey, I just can't get them to stop the donepezil because they're just so attached to it and they're really worried that the dementia is going to get worse off of it. And then I talk to them and they're like, yeah, stop it. And the key is just to be realistic with them and talk to them about, hey, what's the evidence behind this? What's the risk? What's the benefit? And explaining the way some of these things may connect, the way side effects may not be presenting because the patient may not be able to tell us what the side effects are. But if they're having those side effects, then it may wind up making agitation worse. And so therefore stopping it may be beneficial. A lot of families I find have never actually even been told like what the literature says about the medications and what the actual evidence is. And time and time again, when I talk to them and tell them what it shows, they're like, "That's it? That's what it shows?" And So I think a lot of it is just kind of how we present it, how we sell it to them, and And the ones who are kind of like much more with it, and they're like, I've read every article that's out there, and I know that I want them to be on this or that. It sometimes can be harder, and you just have to be really on your game, and or say, we're having a difference of opinion. Maybe you should get a second opinion. But most of the time, I think through a few minutes at least of chatting with family separately, you can break down some of those barriers and get them to kind of sign on to agreements.
Yeah,
We'll
but
talk
really
more
good.
about those risks, benefits of donepezil with lecture number 5, I believe. So more to come on that one next time.
No, but I think that's a really good pearl to like take them outside the room
Oh,
and
yeah,
get them in a different environment. And I think that probably changes the dynamic a lot.
it does. Yeah, there's a lot of tiptoeing that goes around, or goes along, except in the ones that have grown very experienced with it. Eventually, I think some families will realize that, half the time, if you just like talk a little bit quieter or talk a little fast, the patient's not going to understand what's being said anyway, and they can't really follow it, which is sad, but true. So, a lot of times I'll just be like talking with a smile and speed up my talking just a little bit and be like, yeah, and so because of that, I think, it's a little concerning that they're trying to run out of the house and we need to make sure we're guarding the knives, blah, blah, blah. And the patient's just smiling and nodding. So you can do it with the family in the room. It's just a lot harder. And the families often are a lot more resistant to discussion. Other thoughts?
I thought it was interesting how they divided the agitation. I feel like everybody's just always like, oh, they're agitated.
Mm-hmm.
And like, I like that they kind of gave a framework for it because I've gotten that a fair amount of like, oh, they're just agitated. And you're like, well, what is that? Like, how is that manifesting?
Mm-hmm.
And maybe you're going to treat it differently of that, of like break it down into, verbal versus physical and then like aggressive, non-aggressive, because you're
Yeah.
probably, it's going to help you understand kind of what is causing it more than the other things. But like sometimes families just get so stuck on, oh, it's just this. And it's like, okay, can you kind of help to elaborate a little bit more? And I thought that was a great like framework to help me think about it too.
Definitely. Yeah, one agitation is not the same as the other. I know a lot of people use common terms for it that doesn't really describe what's going on. And so, trying to parcel out exactly what's happening, you can do with families, but it often requires a lot of probing and understanding the words to ask, what is it that's happening when they're agitated, and try to parcel that out. It's one of the reasons I like inpatient work so much is, especially at SBH, like, well, I would frequently do to figure out why they're agitated is just stand there and watch them and see what they do when the staff comes up and interacts, etc. Because then you start to see these behaviors and see what exactly is happening. And I frequently will say, like, if you ever do sniff work, you could always tell the rooms at a sniff where patients are that have dementia, because you just have to walk down the halls and listen for the ones where somebody's screaming out, help, help, help. And they'll have the call button and they won't know what to do with it. Or you'll be like standing in front of them looking at them and they're still just screaming, help, help, help. People will call that agitated. But, really, it's anxious. It's not agitation. It's that they are anxious. They don't know what's going on. They're fearful. And that fearful response is not going to respond well to antipsychotic medication. That's the thing that you're going to need to use an anxiolytic for, which, or use calming and redirecting maneuvers. Yeah, people will frequently just say agitated. It's one thing to, in the hospital, if you go into flow sheets, anybody who is agitated in the hospital, the nurses get protocol that they have to do what's called DOS, delirium observation screening surveys on patients twice a day. And as long as they do them right, they are super helpful because it lays out exactly the symptoms that they're having at the time. And so you could see, is it that they're picking at all of their lines? Is it that they're paranoid and they're making up delusions that people are coming to get them? Are they seeing things that aren't there? Are they just anxious and crying all the time? And that can really then help you, since we aren't seeing them every second of the day, to target and see what exactly it is that's going on. It's a lot more helpful than the CAM, which nobody ever fills out right anyway. And even if they do, it's just like, are they delirious or not? So especially on the wards, be sure to look in flow sheets and check out those DOS scores. They can really help guide and target your treatments for agitation.
And just to piggyback on something you just said, Ian, I know you said you like to observe when you're in the inpatient setting and the outpatient setting. I think that's all the more case for really being a detective when people tell you if a family member says agitation or something, like really get into the story, just like you would for a fall or something, the exact circumstances, really hear those details because you'd be surprised how often, especially if a caregiver is stressed and tired and burdened and really just being like, just give me something, like I'm dying here. But like, often the ADL, for example, might be that it's not even the family member. Let's say it's the paid caregiver who is helping somebody with showering. Like one of the common things, right, are private activities that were previously in the adult patient's private world, right? So whether it be like toileting or showering and things like that, which I'm sorry if you already mentioned this, and I missed a tiny bit, but that's a common ADL refusal area. But if you don't get that history or understand what it might not even be, I know this table specifically mentions like for physical aggressiveness, pain, or discomfort, but it might just be purely like, why is this person in here when I'm naked? And
Yeah.
like if you don't get some of those, sleuth it out, that there might be some solutions to try to mitigate that if it's something like that. So I just wanted to say like that's where on the outpatient side, when you're not there to directly observe, it's all the more important to really get a detailed history from the caregiver or if possible, the actual, not just the family member, but the actual person who's with the patient day to day.
Yeah, totally. I completely agree. And when we're seeing people in memory disorders, for instance, I feel like that's the only thing that we do different from their outpatient primaries when they're seeing them is that, when they say the word memory, we delve into it deeper. And what do you mean by memory? Is it that you're having problems with repeating? Is it that you're having problems with misplacing? Is it names? Is it proper names? Is it information that you've been told? And it's delving down deeper into what exactly are we talking about here? And it's the same with behaviors too. But people don't always know where to even start with asking those questions of saying, like, what do you mean when they're aggressive? Do you mean that they're getting upset and they're leaving? Or, with the exit seeking, is it that they're exit seeking because they're scared? Or is it that they're exit seeking because they just need to move? And sometimes the families can't even tell that. But you can usually get some hints by having them just describe and be like, so that's one thing that I'll frequently start with is just like, describe the last time they were aggressive, like go into granular detail. What is it that happened? What time of day was it? What was happening at the time? Where were you? Where was the other people in the house? What were they doing? And just walk them through the episode. And you can usually get a lot of good information that way. All right, we got 15 minutes left, so let's move on to lecture number 2. And I don't have the original lecture anymore. We're in the process of updating the life planning with caregivers lecture right now. So these are in process editing stages. But thoughts, questions about the life planning lecture?
I feel like it really highlighted for me just really how important it is to diagnose this earlier rather than later, and like how helpful that is. if done properly and like given proper information, because so many of these questions get so much harder when the patient can't tell you what they care about anymore.
Exactly. And, this is, I think, one of the reasons why I'm always harping on the fast stage, as inelegant and inaccurate as it is. I think it really highlights one of the most important things about dementia care is that it's all about somebody's function. And what is causing us to progress from one stage to the next isn't a MoCA score. It's not that we're having X, Y, or Z cognitive deficit. It's that our memory issues are making us more functionally impaired. And so the earlier that we can detect dementia, the earlier that we can detect mild cognitive impairment, the more we can focus on the things that matter for preserving function. Because if you are functional, you can have all of the severe dementia symptoms, but not have ADL deficiencies, and therefore you're going to function better for longer. And so, a lot more than what the pharmaceutical companies want to make us believe that early detection is important because then we could get them on treatment sooner. Really, it's early detection helps because then we can start all the things that matter for patients of preserving their function, doing things to lessen their polypharmacy, to strengthen them physically so that they're less likely to fall and have an injury that's going to lead to functional decline that they're not going to recover from because they aren't going to remember to do the physical therapy rehab exercises. Of getting the resources in place to help them with ADLs and to help them initiate tasks when they're starting to have mild dementia, so that way they engage in the tasks and they're doing things that are cognitively stimulating that are going to keep them functioning better for longer. It's really the crux of dementia care, I feel like.
I also thought it was important about like educating the family on like what to expect on like for each stage of like, oh, are they going to be able to like how much they'll want to eat or how much
Hmm.
like they can or because I think that's always like the worst thing for me is like watching them being force fed
Yeah.
um is always like the hardest for me. So it's kind of like, okay, what can they actually do? I've had people that are, bed bound for like a year and they're like, oh, we need to do physical therapy. We need to do all of this stuff so she can get back to the way that she was before. So it can be very hard of like, if they know kind of early on, okay, these, they're not going to, have the same needs as I will or as they did previously, I think can help a lot because a lot of it's like they're wanting them to be like they were before, which just isn't going to happen.
Exactly. Yeah, it's so true. And, helping families understand that it takes time. It's not usually something you can do in a single visit, or even in a year. It takes a long time for them to come to the understanding of this is something that is progressive and is going to get worse. But just because it gets worse doesn't mean that the patient's going to feel worse. You're going to feel worse because you're going to be sad at looking at all this. But the patient's probably going to feel fine through it as long as we don't upset them. But understanding that this isn't something that's reversible can slowly help them to understand and change their mindset of here, we need to change how we're interacting. We need to change our expectations of what we're going to get. And beyond the fast stage, this is one of the more useful tools that I've found is our old SBH occupational therapist was very big on this Teepa Snow's GEMS model. And so Teepa Snow is an occupational therapist who's become kind of a rock star in the dementia world of really defining what it is that somebody can do with regard to dementia. And so this is one that I find can be really helpful with helping families understand how to interact with somebody at different stages. I always tell them, the fast staging system is about what a patient can't do. The GEMS model is about what a patient can do. And I'm not sure. I haven't watched this lecture in a while, so I'm not sure how much they even went into it. That's one thing we're trying to revise is that we made this slide deck as a consortium, and then like one or two people wound up giving the lecture and didn't really seek feedback on what the slides meant. But with the GEMS model, it basically describes that, um, uh, comparing patients to the attributes that we give to different gyms across our life identifies what a patient can do and how we can interact with somebody. So earlier on in dementia is one of the things that we start to find is that patients have initiation perseveration issues. They have trouble starting new tasks. They have trouble when they're on a task of getting off of it. They become very kind of stubborn in that way. And so it's kind of diamond-like, is that they're very rigid, concrete thinking, hard-headed, hard to get them to change. And we see that they can still do all the stuff that they used to, but they sometimes become more territorial, less aware of their boundaries, that they have trouble with change, that they are going to sit there repeating the same stories over and over again, which is going to frustrate you because it's how many times can you hear it before you start getting angry. But if you're getting angry, they're picking up on that anger and then they're going to respond in turn. So, when we're seeing somebody who is in that stage, it can then give us examples of what should we do then? Let's focus on that. If somebody's telling the same stories again, maybe that's an opportunity to parcel something out from that we haven't learned before and to discuss and explore it. Alzheimer's San Diego has this, for example, I think they're downstairs. My kids were playing with them. Otherwise, I'd go grab them. But they've got this card deck of 52 cards of conversation topics for patients with dementia. And what it's meant to do is say, hey, let's sit down and let's play a card game. And instead of playing cards, you're going to pull out questions and be like, hey, tell me about this point in your life or X, Y, or Z. And it gives kind of ideas to families to be able to delve into those stories and learn something new about the patients. They can serve as kind of a useful redirection tool in patients who are in that diamond stage, but also at the same time, help the patient feel competent, feel valued, really identify ways in which they can give back. Because sometimes that's what they're seeking is, that's one of the reasons they're telling the stories over and over again is that they've had these experiences and they want to share it. And so finding ways to get past your own frustration and delve into that can be helpful. Whereas, like if we get down to later stages, like the Pearl, that's basically a fast stage 7. Patients are more locked in. They have expressive aphasia. They may not understand what's being told to them. They may have problems with swallowing, and it's really hard to connect, but we can still connect. Things like pleasant sounds and voices. They may not understand the context of what's being said, but they're going to understand the way it's said. Emotional memory stays throughout the spectrum of Alzheimer's disease. And so being mindful of the way you interact with somebody, the way you talk to somebody, your tone, can really help. Textures and things like that can help. A lot of times this is where we'll say like, hey, go get those like toddler busy boards or busy backpacks with all the soft textures and finger things that they can mess with and manipulate. It helps with kind of giving them something to do, keeping them interested and engaged, and is comforting. So, there are ways that we can adapt at all these different stages, and this and the TIPA Snow website give a lot of information on that and can be a really helpful tool for families, I find. The other thing I feel like I always have to say on talking about this lecture is that beyond early detection of when it's hospice time is another thing that I think is really, really important in dementia care. And so that's one other reason that I harp on the fast stages a lot is because this is what we use for determining hospice eligibility and identifying when it's time to refer. Because what I find is patients with dementia invariably get referred to hospice later than they should. And it's because nobody really understands what to do with dementia patients on hospice. In San Diego, we used to refer, based on the CMS guidelines. CMS says that you have to be a fast 7 of any stage and have a hospice definable illness to be hospice eligible for dementia. But then came San Diego Hospice, and that was our biggest hospice in town back until 2012. They had 1,000 patients at their max. They had this beautiful inpatient unit, just did everything for hospice in San Diego. But then they got audited. And in CMS's audit, they slapped them with tons and tons and tons of fines, and most of it was for their dementia patients. And the reason is that they said that they weren't documenting enough to document decline in their dementia patients to justify them being on hospice still. And it's hard because say you enroll in hospice at a 7A, at that 6 month re-eval, to show that you've declined, you have to move to at least a 7B. But if you get down to 7F and you're still a 7F 3 months later, you haven't declined, so you should be disenrolled. But we shouldn't be disenrolling somebody who can no longer even hold their head up and is completely bedbound from hospice. I mean, that's just negligent. But since it's so concrete, it becomes really hard to justify hospice beyond like the fourth, fifth, or sixth recertification. But they were trying their best to keep those patients on. And ultimately, what we saw with the San Diego hospice data is the average lifespan of a dementia patient on hospice in 2013 was 5 years. And which is great for the dementia patient, but bad for the hospice because it's supposed to be less than 6 month prognosis. But what happened? All those patients that were on San Diego hospice, they got released out into the community because they no longer qualified and the audit said they didn't qualify. Half of them were dead in a month. And really what happened is they then entered back into routine care. We took these patients that were just at home living their best life, getting peri-care or perioral care and all that, and said, wait a minute, they look really bad and they're agonal, so let's put them in the hospital and evaluate what's going on. And then they get delirious and they get restrained and things kind of snowball. And so what we found is that hospice is protective and actually prolongs life in dementia patients. And so the earlier that we can enroll a dementia patient in hospice, honestly, the better both for their quality and their quantity of life. But so you have to learn to kind of work the system a bit to get that to happen. What you'll find now is that to get a dementia patient enrolled in hospice in San Diego, you won't find any hospice that'll accept them at less than a 7B. So they have to be completely deficient in all of their IADLs and ADLs, and they have to be averbal. And that can either be speaking only one word clearly in a day or saying a bunch of stuff that's completely nonsensical and meaningless. The dense expressive aphasia also counts as 0 words. But what I sometimes find is that when the hospices come out, they'll walk into the room and be like, hey, sir, how you doing? And if the patient goes, I'm okay, how are you? They'll just say, great, see you later, and walk out of the room and say the patient doesn't qualify because they said more than one word. So that's when we have to be able to turn around and advocate for the patient to say, yes, we've had this conversation. We've been gotten the family to agree to hospice. We know they qualify, and here's why. Based on a single snapshot, they may have just been having a good moment or whatever. But we can then turn back to them and say, you know, on average, they're 7B. They just were in the hospital for oropharyngeal dysphagia. They've got an aspiration pneumonia in the past. So they've got their hospice qualifying illness. So here's why they qualify. You can also sometimes get them to qualify not under hospice or not under dementia for hospice if they're a 7A by using other things, you know, like protein calorie malnutrition is something you can enroll in hospice for. So say you've got dementia, you're not quite at the 7B level, but just feels like you need to be on hospice. We could sometimes use protein cal malnutrition as a surrogate diagnosis for the primary. And if you have that plus a low palliative performance scale plus dementia, then you say the protein calorie malnutrition is irreversible and you can qualify for hospice that way. There are some hospices that can be more restrictive too. The worst I found was one wanted a dementia patient to be 7D to enroll for hospice. In that case, we just told the family find somewhere else or find a different hospice agency. Because if you're 7D, can't even sit up, that's associated with a palliative performance scale of 40%. Which has an average life expectancy of less than a month. So it's just too little too late referral. There's a chance they may not even see the hospice physician by the time they pass away. But really identifying when somebody is eligible for hospice and making those discussions is important. So usually if I'm seeing somebody with dementia and they're in the fast 6E range, that's when I'm starting to at least plant the seeds with family of now's the time to start thinking about when are we going to transition, so that way it doesn't come as a surprise when we say, hey, it's time to refer to hospice. We're at 4:30, so I will leave with any questions on that or concerns. Otherwise, we can end it here.
All right.